All right, welcome back. This is our next video. I'm going to be talking about peritoneal dialysis catheter insertion. Everything high yield for ABSITE, mostly score-based, if not everything score-based. This is one of the classic score and ABSITE renal surgery topics. Peritoneal dialysis catheter insertion. We'll go through indications, contraindications, operative setup, catheter placement techniques, troubleshooting, complications, and any high yield ABSITE pearls you may need to know. You should be able to, at the end of the video, understand the procedures from the start to the finish and recognize the major complications and management decisions. So let's get started. What is peritoneal dialysis? Peritoneal dialysis uses the patient's own peritoneal membrane as a semi-permeable dialysis surface. Instead of filtering blood through a hemodialysis machine, dialysate is infused into the abdominal cavity through the peritoneal dialysis catheter. The fluids and toxins diffuse across the peritoneum, and then the dialysate is drained out. The catheter therefore becomes the patient's lifeline, and proper insertion is critical for adequate dialysis, prevention of infection, and maintaining long-term function. What are the indications? Patients are typically considered for renal replacement therapy when their estimated GFR falls below 20 and 30. Peritoneal dialysis is especially useful for patients who prefer home dialysis if they have residual renal function, if they have minimal prior abdominal surgery and can reliably perform exchanges at home. Advantages of peritoneal dialysis include greater independence, hemodynamic stability, and avoidance of repeated vascular access. What are some of the contraindications? There's the absolute contraindications and the relative barriers or relative contraindications. For absolute contraindications, this include active intra-abdominal infection, if the patient has severe protein calorie malnutrition, if there's an ultrafiltration failure, or if there's a general loss of abdominal domain with excessive adhesions from prior surgery. Relative barriers include obesity, advanced age adhesions, and but not significant adhesions. So surgery in itself is not an absolute contraindication. And then polycystic kidney disease. Even hernias, ostomies, and previous surgery are not absolute contraindications for doing this. Timing and preoperative preparation. Ideally, the catheter should be placed at least 2 weeks before dialysis begins. Why? Because early use increases the risk of dialysate leaks, exit site infections, and catheter dysfunction. In emergencies, however, dialysis may still begin within hours after placement. Hernias. For patients with abdominal hernias, staged repair is preferred over simultaneous surgery. Why? Because peritoneal dialysis increases intra-abdominal pressure, and this increases the risk of dialysate leaks again, incarceration of bowel through the hernia, strangulation, and even peritonitis. So let's talk about the operative techniques. One, positioning, exit site planning. So the patient has to be in supine. The catheter exit site you should plan out and should avoid belt lines, scars, skin folds, areas that may be prone to moisture. So good exit site planning is one of the biggest determinants of long-term catheter success. Next, you're accessing the peritoneum. So this can be open, laparoscopic, or percutaneous. Particularly laparoscopic is helpful. This placement allows for direct visualization, lysis of adhesions, confirmation of catheter position, and evaluation of hernias. Next, let's look at catheter positioning. The catheter tip should rest deep in the pelvis, usually in the rectovesical or rectouterine pouch. Why the pelvis? Because gravity. Gravity improves dialysate drainage, and a catheter placed too high may migrate and malfunction. So next, look at tunneling and cuffs. Catheter is tunneled subcutaneously. Most PD catheters contain two cuffs, a deep cuff and a superficial cuff. These cuffs anchor the catheter, reduce infection risk, and create a fibrous seal. Before closure, test the catheter. The catheter should be flushed, drained, and check for leaks. Troubleshooting a dysfunctional catheter. One of the most common postoperative problems is a catheter that's dysfunctional. So the most common cause is actually constipation. A stool filled with colon can compress and displace the catheter and impair drainage. So bowel management is often the first step for these patients. Next, let's look at imaging. If dysfunction persists, obtain an X-ray, an abdominal X-ray. This helps identify catheter migration, kinking, and displacement of out of the pelvis. Next, let's look at fibrinolytic therapy. So if constipation is treated and the catheter is correctly positioned and the obstruction persists, then fibrin obstruction may be present. In these cases, you could consider flushing the catheter with heparin, or TPA may be used as well. Salvage procedures. So if conservative measures fail, and the last salvage procedures could include fluoroscopic manipulation, laparoscopic repositioning, and then even open revision. So let's talk about complications of peritoneal dialysis catheters. The most important complication is peritonitis, referred to as peritoneal dialysis-associated peritonitis. The presentation typically is someone that develops abdominal pain, fever, and cloudy dialysate. And the organisms that we frequently see are gram-positive cocci, enteric gram-negative bacteria, and fungi. Diagnosis is typically made by taking the dialysate, analyzing it, which shows increased WBC count, usually over 100 cells per millimeter cubed, and with greater than 50% PMNs. This is actually pretty classic. You can see this on some of the ABSITE questions. Treatment requires broad coverage, so you can use vancomycin or a first-generation cephalosporin, plus an aminoglycoside or a third-generation cephalosporin. And these antibiotics are often given intraperitoneally. That's important. When to remove the catheter. The catheter does not automatically need removal for everything. It's typically only reserved for fungal peritonitis, refractory infection, or failure to improve after 4 to 5 days of antibiotic treatment. Exit site infections. Exit site infections present with usually redness at the area, drainage, and even some tenderness, and treatment is usually just antibiotics, meticulous wound care, and closely following these patients to make sure it doesn't worsen. These usually do not require catheter removal unless the infection is recurrent or refractory. Catheter migration or hernias are late complications of peritoneal dialysis catheter, and again, is not usually indications for catheter removal. That's pretty much everything that we've covered in terms of peritoneal dialysis catheter placement. Let's review do the ABSITE high yield review, rapid review. So first, ideal catheter tip location, that is in the pelvis. Prior surgery, remember, is not an absolute contraindication to peritoneal dialysis catheter placement. Ideally place catheters 2 weeks before dialysis if possible. The emergent can be done. Most common catheter dysfunction cause is actually constipation, so do your bowel regimen first. X-ray evaluates migration or kinking, should be used first. TPA may treat fibrin obstruction if nothing else is working. Peritonitis is usually the most common complication, devastating one. Which presents as cloudy dialysate with abdominal pain. Think of infection. Fungal peritonitis usually requires catheter removal, and exit site infections, as we talked about, usually is treated without removal, just antibiotics and close follow-up. Again, this is a score-based overview of peritoneal dialysis catheter insertion and management. I do everything ABSITE and score. So please share it with your co-residents, share it with medical students, whatever you need to. Thank you for watching. Please like and subscribe, and stay tuned for more videos.